Nursing Conversations. Today, we're discussing maternal and infant health advocacy, Black women's perspective on breastfeeding, and how the award-winning Dr. Nastassia Harris, she, her, hers, founder of the Perinatal Health Equity Initiative, registered nurse, and IBCLC, stays on the front lines of keeping the community involved and what she has in store for the future. I'm your host, Ria Anopise, and I'm joined by an award-winning AWHONN member who's also a co-host of this podcast, LaShea Haynes, editor of Healthy Mom and Baby magazine, L&D, mom and baby staff nurse, wife, mother of 3, and nana of 1. LaShea, I'll now turn the podcast over to you.
All right. Hi. Welcome. Yes, we are so excited and appreciative to have Dr. Harris here with us today. And yes, congratulations on your most recent honor.
Thank you.
We'll have to get into that a little bit later on, but I want to jump right in to the questions that we have for you.
Okay.
That our audience wants to know. And so the first one that we have for you in late April, AWHONN was on Capitol Hill in Washington, D.C. Mm-hmm. Were you aware that the Momnibus Act still has not been passed and legislators are now working to get the bills passed individually?
Yes.
And so I want to know, what are the first 2 bills that you'd like to see passed from the Momnibus Act?
Yeah. So what I will say is very interesting about the Momnibus and kind of where I see things going, and I'm going to answer the question. But what I have seen states start doing is work that same way of passing them individually at the state level, because the federal process has been taking so long. And so I would love to see that happen at a larger scale, and hopefully that will move things forward faster. But I picked 3. And I'm just going to go through them really quickly.
Okay.
For us, because we're a community-based organization and we spend time on social determinants of health, that was our priority, is making sure that there is the social determinants of Moms Act is addressed. It's very hard, and nurses, we've been steeped in Maslow's hierarchy of need. It's very hard to address all the other things when you have to worry about if you're going to be able to eat, where you're going to sleep, your income. All of those things really do have serious consequences on the outcomes for Black mamas, and for all mamas, but specifically for Black mamas. And so that's definitely a high priority for us. The other was the Kara Johnson's Act, which really talks about funding going to community-based organizations. So of course, as a community-based organization, I would support that. But I will say, as a Black-led organization, we are not just mine, but across the country, historically underfunded. And so having money that is designated specifically to community-based organizations who are at the community level doing this work is only going to help us to magnify that impact. And so that's really, really important. And then the last one I will plug is the Impact to Save Moms Act, which really talks about new structures on billing. Our model combines nursing care with community health workers, both of which are unbillable services. And so the care that we provide is really, really important, but we have no mechanism of reimbursement for any of the services that we provide. And I know there is talk about reimbursement for community health workers through at least Medicaid, but I want to also remind folks that this is not a poor woman's issue. This is a Black maternal health issue, regardless of where your income is. And so we can't just rely on the Medicaid system to address this. It has to be all of our commercial payers as well.
Wow, you really touched on some pretty important things there. I appreciated what you mentioned just about it's not an income thing. And I think oftentimes, even in classes that I'm teaching, when I ask people, what are social determinants of health? Oftentimes people go right to your educational level, or it's, people's income level. And I think that for us as nurses, people they don't want to offend others. And so by, attacking education and income, I think makes everybody else in the room feel comfortable and safe, because as a nurse, you minimally have some degree, right? Whether it's an associate's or a bachelor's. Right. And so people go right to that. So I appreciate what you said as far as actually the CDC. I share that infographic that they created just last year that said Black women are 5 times more educated than the average white woman. So it's not about income level.
Yes.
As you said, any of us, we're affected by social determinants of health. If you live, and I give the example, if you live in a food desert, even as a doctor, when I'm tired and I get off work and I've just worked 12, 14 hours and I'm tired, I don't want to drive 45 miles to get to the Whole Foods, right? So I become just like the community, where now I'm going to go to that same Checkers or Church's Chicken or whatever, whatever is available. I'm going to eat it too, right? Like I tell people, the only difference is with the income, I might be able to get a sleeve or gastric bypass or right. I can get, my doctor friends to write me a prescription for Ozempic or whatever everybody's taking. Right. So I might be able to hide, right, that I'm affected by those social determinants of health a little better because of my income, but I'm absolutely still impacted. So we actually do a disservice to ourselves by not admitting, right, that, hey, guess what? No, we do deserve to have fresh fruits and vegetables. All of us do, no matter what our income is. Absolutely. We need it in our neighborhoods, and we need more people to see that. Yes. That, like you said, it's a health crisis for all of us. When a baby goes to the NICU, it affects your, if you have to get your appendix taken out or gallbladder, or, whatever, you know what I mean? Your surgery is 3 times higher in a state where you have all this infant mortality, that you have to recoup that money.
We're all paying for it, absolutely.
In some kind of way. And so we're all paying for it. So that, I really appreciated that. And also what you mentioned about community-based organizations, which is why we really wanted to have you on the podcast. I think it's great for those, our mothers or grandmothers of OB who did their service and, worked there 20 or 30 years in the setting. And oftentimes, yes, they're still public speakers and things, and they have something to say, but there's also something to be said about those that are, feet on the ground and that are doing the work every day.
Yeah.
And so we appreciate you for that, because our women need that. They need people that, care, that are in the community. And yeah. So we thank you for that. Yeah, that was great. All right. So we're going to move on to our next question. As an IBCLC and an advocate for improving Black breastfeeding outcomes, can you share insight on the patient's perspective?
Yeah. So I'll start by saying that my doctoral research was focused on barriers to exclusive breastfeeding for Black women. And I didn't focus on whether Black women were breastfeeding or not, because that's not what I saw. I saw Black people were breastfeeding and really had a strong desire to do so. I found that they were not meeting their goals. And what I uncovered is it is we, the healthcare providers, that are the disruptor in stopping that from happening. So things like imagery, that's one thing that's real big for us as an organization. Anything you see that comes from us is going to represent Black women. That is what we immerse ourselves in. That's important. And our community has said that. We don't see ourselves in things. We don't think it's for us. And that rang true a lot with breastfeeding, is that people didn't see the images when we give our handouts, the pamphlets that we choose often don't reflect the community that we are serving. And so that does have, its own bias, implicit or not, on how people interact with that content and information. The other was this assumption that Black women were not going to breastfeed. And there's even an article entitled, Why Bother? They're Not Going to Do It Anyway. And it really focuses on the fact that we're just not having a conversation. The question is, what formula are you going to use? Not how do you plan to feed your baby, or what have you heard about breastfeeding? And we know how important it is when a provider talks about breastfeeding, that choice, and doesn't do this middle of the road approach of, fed is best, which is a term I strongly dislike. That's besides the point. When we play that middle of the road, whatever you do doesn't matter, then women are less likely to choose to breastfeed. And that conversation is really important. Regardless of what you choose, yes, in the end, the baby is going to be fed, right? But the nutrition and the health outcomes are going to be different when a baby is breastfed. And this is an implication that rings true, not just for the baby, but also for the mother. And this is something we have been really interested in talking about as an organization, because we don't view breastfeeding and chest feeding as feeding. That's one thing that it does, but the bigger picture is the health outcomes that are changed. When you look at our leading causes of death for Black women, cardiovascular disease, the risk is significantly decreased for Black women with longevity in breastfeeding. When we look at things like postpartum hemorrhage, right, we know there's a connection to early breastfeeding and reducing the risk of hemorrhage. Breast cancer, Black women are more likely to develop breast cancer and aggressive forms of it. Breastfeeding is one of those tools that we can use to reduce. So it's not that it's zero, right? It's not going to ever eliminate it completely, but these are the things that we can be doing to help support future health outcomes. And so I think when we begin to shift how we talk about breastfeeding as more of a public health conversation and less as a choice of how we're going to feed our babies, the outcomes might be different. But I will say that what has come up frequently in nursing is our hands-on skills are not great. We have a lot of content and education, but we don't always have the ability to apply it to patient care. And so the classes that we take, being mindful that there is some sort of hands-on component that you get to actually practice those skills, that you're working with the IBCLC on the unit if that's where you're placed, so that you can actually use those skills, and that we're not just kind of spitting out information that doesn't translate to actual practice.
Absolutely. Wow. That was great. I would have to say that I agree with you as it relates to the fed is best. That, yes, we're not going to shame anyone who doesn't want to breastfeed. It's a choice, right? And if they choose not to breastfeed their baby, then we're going to support them in that. But like you said, I think a lot of times when we go in and it's just, well, fed is best, and as long as the baby eats kind of thing, it allows nurses sometimes to not prioritize, right? Right. Not prioritizing. And that's coming from somebody who is a mother baby, staff nurse, that if I have that attitude, oftentimes for my own bias, it can be, if I'm too busy, well, fed is best anyway. So let me just go take her a bottle, right? I'm too busy. Let me get the tech to just take her some Similac in there because I'm actually too busy or don't want to, right? Latch the baby on, or I'm at a lunch break or whatever it is that I'm doing. And so, hey, fed is best. And so we'll just take her some Similac in there and, she can supplement as long as the baby eats. Kind of thing. Yeah. And it does disrupt that initial breastfeeding experience for that mother. Human milk is what's best for humans, right? And coating their gut with human milk and the probiotics and the enzymes to help them to break down food later. Even the formula reps. I just, in 28 years of being an OB, they tried years ago to say, formula was the same, and, they would name all the bells and whistles, right? That was in the formula, and, that there's, a gluten and DHA and whatever else, all the bells and whistles. But now their message has even changed to liquid gold is best. We're not going to argue with that. Right. But when you want to stop breastfeeding, no judgment over here, Enfamil / Similac, right? Just pick us. It's pick us. And so I kind of support their theory, right? More than I would the whole fed is best. I kind of like their new slogan of no judgment, right? Breast milk is best. But whenever you are unable to do that anymore, whether that's a week, 6 weeks, or 6 months, we just want you to remember us when it comes time to feed your baby. And
that's their job, right? As a company, I think that the disadvantage we have is we don't have commercials for breastfeeding. You can't turn on the TV or go on the internet and see any type of advertisement that supports the benefits of human milk. We can talk about those things, but I think most families understand the benefits. They don't understand the application. Most of them struggle with actually doing the breastfeeding. And so we do a disservice when we don't create connections after discharge, right? That's one of the things that we do as an organization. When people go home, connect them to someone. You may not have the time to do all the things in the hospital, and you have, realistically 36, 48-ish hours to do a lot of things. Everything is possible. But recognizing that, this is this mother's goal. I want to honor her goal. And so I'm going to connect her to this community organization or this support group so that she can be successful. It's really just closing that loop.
But, and that brings me to another thought that I had, just as you said that about the community connection. how do you make sure that moms know that you have this service and that it is available? Do you have that connection with your local birthing facilities so that they can, send moms in your direction?
I would say that is a relationship that takes a lot of work to build. Coming in as a small grassroots organization and competing with much larger organizations who on the surface appear to do similar work, we've had to really work hard on our theory of change, which was a new concept for me of like how we know what our model is of how we do work, but being able to articulate what's different about what we do in contrast to other organizations has been key in creating those relationships. So we did just sign on with one of our bigger hospitals to be able to provide support and information to their families as they're being discharged. We rely heavily on social media. That is where a lot of our families come from for support, being able to be found on Google and things like that. And then, of course, word of mouth, which is our favorite way, is that someone who benefited from our services then goes back and tells someone else and provides us as a resource to them, which means they found what we gave them valuable. And that those referrals mean the most to us. But yes, networking within the community, other community-based organizations. We've been really diligent with trying to build relationships with our community-based providers because the hospital is where people focus a lot of their attention, but there are pediatricians or OBs that have private practices in the community who aren't looped into a lot of these things and aren't having these conversations. So we're working to build community with them so they can, use us as a trusted resource as well. So it's multimodal. I will say the one area that we need help on is TikTok. We did do a focus group just to ask, like, if you had a question about pregnancy, where are you going? And a lot of our moms said TikTok. And I was like, well, we ain't really on the TikTok yet, but we're working on it. That's I'm not that generation. So we're looking to bring in some folks who understand that world a little bit better so that we can have a presence on those places too. But I feel like if our families are on social media, the least we can do is make sure the information that they receive is evidence-based and it's not just coming from influencers and other people and their experience, but there's actually like fact-based information that they can rely on.
Okay. So our next question for you is Dr. Harris, you are constantly on the front lines of working for the community. Do you have any mentors who have guided you, and why is mentorship important as a nursing leader?
So many women, and I am eternally grateful for that. I can say that in this space, doing work that I come from a lens of, being a nurse. I was groomed in a hospital environment. And so what I thought was community is what I was shown in nursing school, which was at the adult daycare. So what I thought about what community was, I kind of stayed far away from that. But as I got into community work and began to introduce myself to works like Dr. Monica McLemore, who has written as a registered nurse an extensive body of work in this space, I am blessed to be able to call that woman a mentor. I know if I text her, call her, she will take my call and offer so much of her time in a way that she does not need to. And so I am internally grateful for that. And I would say Dr. Karen Scott has been the same for me. As researchers, I chose a DNP path, and that was great in the moment. But when I got into this space, the work that I needed to do really required a PhD, if I'm being honest. And so I am learning those things, and I will probably go back and do that at some point. But having people who have that as a background, who know research intimately, but then also understand the grassroots community issues has been invaluable to me. Kimberly Seals-Allers has also been super important. Being connected to the Black Mamas Matter Alliance and the wealth of organizations that are in there as a think tank, that if I send a message out, someone will respond and offer some sort of support. So I have been grateful to have those people around me, but it is the most important thing that you can invest into. I'm grateful to have people that pour into me that I do not have to compensate them for, but I do have a coach that I do pay for. And that has also been really, really important. There are just things about certain aspects of work that you just don't know. And if you are not open to acknowledging that you don't know all the things, so that you can grow yourself as a leader and grow what you're doing, you're being very short-sighted with your approach. So I would say that having a coach is really, really important in whatever the specialty that you're in. So whether that's a mentor because you want to go into a leadership role, and so maybe you've selected someone who's a manager, nurse manager, if that's the direction that you want to go in, so that you can learn. There is a playbook, a hidden playbook, right? And so if you don't know, if you don't have access to the playbook, there's things you're going to miss out on. So having access to mentors is super, super important. So that's a plug to nurses to remember to reach back to those once you've ascended, remember where you were previously and what steps it took you to get there. And if you have the capacity to reach back and give it to others is so important.
Wow, that's great. I mean, you actually answered the follow-up question, which was, what ways do you invest in your professional development and that of your team? And so that is great that you pay like you said, a mentor and a coach, because we all have something we can learn from someone else. And so I think that definitely that just shows your level of commitment to the work that you're doing in your community organization, and how important that is, of wanting to know all the things, and being able to reach out not only to your mentors, but to your paid mentor as well, your coach, to help, like you said, to support the work. So it just really, like I said, speaks volumes to how important this work is, as we can see, to you, and I'm sure to the mothers and the families that you serve.
But that's the nursing model, right? I remember being groomed that way as a young nursing student, that you're supposed to be a lifelong learner. That was something that our faculty taught to us consistently, and I've never lost that. There's always a need to keep learning something, especially in a field like medicine. It is changing all the time. And so if you're not reading articles and attending conferences or webinars, whatever it may be, you're going to be stuck in a time period where we're no longer practicing. And unfortunately, that's what we see happen often, right? There's a 10-year gap between when a research article comes out and when that research is actually implemented in practice. That is too long. We don't have that type of time. And so if we're all pushing that forward because we're reading those things and we're pushing that agenda, we can hopefully close that gap and narrow it a bit.
Yeah, unfortunately, I would have to 100% agree with you. In the classes that I'm teaching, I remind nurses often, just an example of that would be QBL, right? Quantified blood loss, the AWHONN practice brief, making that an expected standard, came out in 2014.
Yeah.
It's an expected standard 10 years ago.
Yeah.
And it wasn't real until
10 years now.
Yeah. It's 10 years. And we're just at the point where I asked that question in a class, and I can get at least, even, it's still not even 100% 10 years later, but I would say maybe 75% of the nurses will say, yes, we're practicing each and every time doing QBL. So I would absolutely have to agree with you that's way too long when you think about the lives that have been lost within this time period. And the excuses sometimes we don't even realize we're making. It was, we're in COVID. Well, it doesn't matter that there's that we're in COVID. We still have to, right? When the baby's delivered, there's still blood, and we need to count it. And what does that have to do with, right, the pandemic that is going on at the bedside? We still have to provide evidence-based care. So I think that we definitely need to narrow in that gap from, when a standard or evidence-based practice comes out and says, this is what the expected standard is. We need to be moving a whole lot quicker than what we are. And then I think that's what speaks to why the preventable deaths are so high, right? Where no matter what state we're in, you can look at almost anybody's morbidity and mortality review committee report, and they all are reporting somewhere between 86 and 93% of the deaths are preventable. And some of it speaks to what you just mentioned.
And how frustrating is that? Like, when you look at the data, like, I read our state's review report. It literally says like all the things to do to make this not happen again, but yet we have not implemented the things that the report says to do. Like, why? We keep wanting to make new research. I read something by Dr. Fleda Mass Jackson on Black infant mortality. And when I was doing some research, this document was dated 1996. And I said, this is literally the answer to what we need to be doing. Why have we not done this? I don't know what happens in translation, but like, we don't always need to do new research. Like sometimes there is existing things that we could just move them forward and we could make so much more progress, but we're not quite there yet. Hopefully we can get there soon.
Yes. I would absolutely agree with you. So congratulations again. I said we would get back to you being the 2024 award winner of the Diversity and Equity and Inclusion Award. Huge honor. Can you describe the rewarding moments in your work to improve maternal health outcomes and how that, led to you getting this honor?
Yeah, I mean, I've been blessed to be involved in so many different things, but I would say leaving the bedside and creating the Perinatal Health Equity Initiative is probably the one thing that I am the most proud of, to be a nurse in this space, to create something from zero budget and a team of myself, and then be able to grow that and hire nurses, be able to hire people from the community to reach back and give to the community is probably the thing that I am most proud of. I have been fortunate to contribute to a lot of things with AWHONN, with the Respectful Care Initiative, which was a team of amazing writers. I learned so much from that experience itself, being able to write position statements for AWHONN on nursing and inequities. But then also just, I'm no longer in this role, but having been a Black faculty member, which is unfortunately a rarity in our space. And I wrestled with that decision to leave the faculty role to focus on the nonprofit because of the gap I would be leaving there as well. But really taking the learnings that I've had from the community and infusing them into the classroom with our young BSN students was super rewarding. So I've been blessed to have a career where I have been able to do so many different things and impact the profession in so many different ways. So I'm super grateful for that.
Yes, I would have to agree with you. I worked as well as a nursing instructor for 2 years, and recognized how much the need was there for diversity in that space when nurses are learning, right, to help to kind of almost unpack those implicit biases, trying to, accomplish some of that and introducing some of that language and just what is that and what does that, look like, and how do I ensure that when I'm taking care of my patients, those implicit, explicit biases don't show up. And I think not having people of color to even just explain some of the experiences of just when you don't know, you don't know. I mean, like you mentioned earlier, sometimes you don't even know what you don't know. Yeah. There's often times where I'm even explaining classes that I'm teaching now, just even about people who may be on government assistance who are not married. And so, you may look at it as a moral issue of not wanting to be married, but I have news for you, right? When you have government provided homes, they kind of don't allow it. You have to pick or choose either, right? And this is what I say in my classes. They have to kind of pick. It's Jamal or it's the government. You become married to the government essentially, because you cannot have an income. So when you're kikiing at the desk and, giggling about, why this man has 2 different women, right, that are having babies, I can answer that for you, right? Because you don't have that experience. I understand what his issue is, and it's because he can't stay. In addition to her having governmental housing, his name's not on the lease. And those leases also include no one with a criminal record. So there's a double whammy there, where even her own teenage boys, right, who may be arrested for something, even a crime they didn't commit, at the end of the day, right, if they take a plea deal, they still have a charge. So they're still winning. The government is still winning, because now her own children can't stay there. And so that's why he has children by multiple women, because there's 7 days in a week and he needs to sleep somewhere all 7 of those days. And so if he only can stay with mom a couple of days, right, and he only can stay over here for a few days, he's over here for a few days, then that's how he has multiple households and multiple, right? And so that just, it speaks to just an example, right, of just, if you don't know, right, because you grew up in this, middle class neighborhood where you only saw married families. And so you have no idea. And so I think that you're absolutely right that was one of the things that I struggled with when I also left teaching, was, man, this is, they're gonna lose this, and hopefully there'll be somebody along the way where they'll ask those questions, because we choose where we work.
Yeah, there has to be a counter narrative to what's in the textbook, and I've always struggled, even as a student, like, what Black people are you talking about in this textbook? Because I don't know these Black people. I don't know what you're talking about. But if you're not familiar and that's what you get taught, that's what you learn. And there was a lot of unlearning that I had to do when I left the hospital and went into the community. A lot of ways that I was taught to think, the cultures that I was groomed into, were wrong. And someone has to disrupt that for you. And I hope that I did a good job of doing that for our students, is just having them rethink and reframe, talking about cultural humility over cultural competence, and really helping people to understand that there are lived experiences that you're not going to be able to understand them in the same way of someone who's lived that life, but you can keep working to understand, keep questioning things. Why is this thought popping up in your head? Why are you wanting to do a drug screen on this individual, but not this one over here? Why is that your practice? And just that curiosity in questions. There was and I'm going to get the name wrong, there was a series of videos that came out, and Dr. Monica McLemore was one of the nurses that was featured. And it talks about curiosity, right, as that being a foundation of nursing, to always ask the next question and always be curious to learn more. When we just accept information as fact and we don't ask any more questions, that's where the bias begins to fester, because we're not questioning, this is our policy. Well, your policy is racist, but if we're not asking the other questions, we're just looking at, this is just what we do. And, we have to learn to think beyond that.
Absolutely. And actually, what I was doing when you were talking was pulling out, because I saved it as an example, just to test to what we both just said. This was made by Lippincott, right? So this is something that the types of things that people would value, right? It says maternal and neonatal. I know it's coming up backwards. So for those of you that are reading this, it's from Lippincott, and it says maternal neonatal facts. I got this at the AWHONN convention. This was the year we were in Tampa. And I remember going to the booth last minute. So they were packing up. So unfortunately, I was not able to go back to the booth, but I wrote a letter. And every chance I got at every conference moving forward, I made sure that this was removed and that they came out with another edition. But in this, they did have, like you said, what they considered cultural, competence. And it was so embarrassing. This is embarrassing. This is racist. And it has nothing to do with ethnicity, of more of really social determinants of health. What's listed here is that African Americans may delay prenatal care. What does that have to do with somebody's ethnicity? They may delay, right? If they delay prenatal care, I guess it's because they're living in a maternity care desert, but we won't talk about that, right? We're just going to label, like you said, Black people as they just delay, right? Like as if it's just not important to them. May delay. Believe taking pictures during pregnancy may cause a stillbirth. I've never in my life. I'm still asking Black people to this day.
Heard any Black person.
Me neither. Bria, I don't know if you've ever. We got 3 Black people here. We're all looking real confused, right? And this is Lippincott. Like I'm not making this up. This is in a Lippincott that we don't take pictures because we believe in still. I still haven't found anyone that believes that. I don't even know where they got their information from. It says there's a few others that are just as may prohibit tub baths and shampooing their hair in the postpartum period. Again, never in my life. I've been a nurse 28 years and haven't come across one Black woman that doesn't want to shower or wash her hair after birth. So I just don't know. Like you said, this is reckless. May view breastfeeding as embarrassing and therefore bottle feed. May introduce solid food early and may place a belly band on the neonate to prevent umbilical hernia. So there it is.
I would say that it definitely speaks to everything that you and Dr. Harris have been saying. There was no one of color, any color, that provided to that document. Nobody of color read it. and said, stamp, this is good, let's publish it.
Mm-hmm.
And so you feel offended when you read it going, wait a minute, this doesn't apply to anyone that I know. Why would we put this out there without them being involved and saying, hey, let's change this. Let's make this so that someone who picks this up walks away and has a better understanding of how to take care of people of color. Why is it divided by race anyway in the little booklet?
Yeah.
Mm-hmm.
Yeah. I mean, there are, I can just share very briefly, there was a mom that we recently worked with who ended up having a stillbirth. But the reason she had that stillbirth is because it took 2 months for her to get a prenatal appointment, right? Not because she didn't want to go to care, because it wasn't important to her, but because the place that she went for care was so overwhelmed, they did not have an appointment to give her. And so as a result, in her chart, they wrote high risk, late entry to prenatal care, right? As if it's her fault that happened. And then, she had history of preterm birth. She ended up dilating at that appointment. She was 20 weeks already at that time, and the pregnancy could not be saved. So again, when we think about how we document things in charts, how we tell this narrative and the story, we left out the part about how she went when she was supposed to get care, and she was denied access. And now this outcome is viewed as her fault somehow because she was late entry to prenatal care. And that's not the entirety of the story of what happened. What you've hit on a lot, LaShea, is the structural changes, the system that creates these things to happen. But we don't question that. We just look at the individual and how they showed up for this thing, or how they were late, or whatever the situation was. We don't look at how they didn't have childcare, how they didn't have transportation, how they couldn't take off work. Like, there are so many other things that contribute to that. It's never just, this is a non-compliant individual, which is also a phrase that I hate.
Mm-hmm.
Non-compliant is meaning that you're giving information in orders that someone is supposed to follow. And because they did not follow you as the provider's orders, they're now non-compliant with what you directed them to do. That's not the essence of informed decision-making. So that's something that also is like an annoyance of mine as well. But there's the issue is deeper than that. And when we talk about textbooks in general, I don't think I know any Black women who have contributed to a nursing textbook, right? When you look at the authors, it's almost always the same author rewriting it over and over again. Maybe you get a chapter here and there, but your name is never on the cover of the textbook. And so when we think about who's writing the content, that matters as well, because that content is then grooming the next generations of health professionals that we have coming out to practice.
So I would have to agree with you, Dr. Harris, as far as a non-compliant. That is something else when I'm teaching my AWHONN classes, where I talk about we're not parole officers, right? And so sometimes in healthcare, I often feel like people get that a little bit confused, right? They're not MRN numbers. This isn't jail. Where they're by their MRN number 5623456, right? Or even just patient refused to do. So words like you said, non-compliant, refused. How about respectfully declined? And a lot of time there's a reason why. You said, you offer a suggestion of maybe what a care is, but shared decision-making is coming to you. You're hearing the patient out, right? And I have a suggestion, and then I give that to the patient. Right. Let's come together and see what's going to work for her and her situation and her family. And sometimes one size fit all is we can't have that model in healthcare. If there's not one size fits all, we have to make it fit for each and every family. So I would have to agree with you there that we have to kind of get out of that mindset. Like I said, that we're not parole officers. And if we're here to truly care for the communities that we serve, and have the compassion that nursing is supposed to have, right? It's supposed to be the number one compassionate profession. Let's not forget that, right? And so when you get to the point where you come to work and you're not able to provide that compassion, kind of start, it's
probably found it. Take a seat.
It is. Retire or find something else to do. Walmart greeter, whatever. In a flower shop, I don't know, but yeah, when you can't provide that compassion anymore, it's definitely time to go. Yeah, patient care is not for you. Yeah. So yes, thank you for that. And so I have another more personal question. Is there anything in particular that you do to stay motivated or energized in this type of work? And some of the things we just talked about, it can be exhausting, overwhelming, right? It can be a lot to unpack. And so, leaving with feelings of despair, how do you prevent yourself from getting to that point?
I'm mindful with taking breaks when I need to step away from something. And I think that's hard for me in this space because it doesn't always feel like work. It is something that I am extremely passionate about. And I could go from sunup to sundown working on something and not really think about it at all. But I need to be intentional about pulling myself away from things. So that is a thing that I am working on. I would say being a member of organizations like the Black Mamas Matter Alliance, being in community with other Black people who do this work, who understand, who I could just enter and show up in the space and not need to think about how I'm presenting in that room, the words that I need to choose to use, to just be authentically you is so important. I think that's one of the things that I vowed to never do again in this space is code switch. I refuse. And I think there's freedom in releasing certain things of how you were told to be and show up in certain spaces. Not needing to do that and just being aware of that really does help to free you up to be who you are as an individual. So that extra layer of stress of having to worry about how you're being perceived, it took a lot of time to undo that, but that to me was healthy. That was me taking care of myself, is that I'm going to show up this way. And because this is who I am, and you either accept that or you don't. The other is if there are spaces where I am not accepted, I'm not fighting to be in those spaces. Like there are some times when it's worth doing that. And other times when it's like, you know what, this is not worth my energy. Y'all can have this and I will go to what I need to do over here. Because sometimes the fight of that energy is more exhausting than what it's doing. And you shouldn't do that alone. I think that's another thing that I learned from Dr. Monica McLemore is not being an only in a space. When you are the only Black individual, the only Black person of color in that space, it is hard to be in that room. And I also said I would never take a job where I am the only Black person. It doesn't work. And so I think that freedom, having that set of rules in your own brain about what you will accept and what you won't, will help you to navigate spaces. So I would say that's really important. But then also we started doing a mission moment, right? With our board and with our team of where are successes of the work that we have done. Like we can't sit in doom and gloom all the time. We have had really beautiful stories where there have been amazing outcomes with our families. Let's talk about that too. So let's make sure that as we're talking through all the things that we need to work on, we're starting the meeting with something happy. What is your mission moment? Where did the mission show up for you this week, or out in the community, or whatever the case may be, so that we can always recognize those high points, so that we're not solely centered on those low points. And that is rejuvenating, because despite the fight and how hard it is, there are real lives and people that are being changed from the work that's happening. And that's why we do this in the first place. So being able to see those things come to life. And I'll just share briefly, there was a family that we supported who very early in her pregnancy was told she was having a miscarriage, and she was not having a miscarriage. So that's the whole separate story. But being able to go through her pregnancy with her, being able to show up to the hospital and hold that baby that we were told was not even going to exist. I would say for my career, that was a high point for me, being able to hold that baby, watch that mama breastfeed. This woman has a freezer full of breast milk, right? Those are the stories that we live for, because that's the work. That is us showing up for the mission, for what we designed to do, and seeing people thrive from this space and the work that we're doing is really how I rejuvenate. So thank you for letting me share that.
Yes, no, I would have to agree with you. I think I've also kind of created that boundary for myself. And I think I'm kind of proud that people know that, right? That I'm not going to be just a seat filler, or I'm not there to just check the box.
Right.
And I think that people know that about me, that if you want me in the seat, I'm going to be present. I'm going to have an opinion. I'm going to speak on it. I'm going to raise my hand. I'm going to have rebuttals. And so if that's not what you're looking for, then I'm not the person for your project. Or like you said, I cannot be. And that does help I think with that, like you said, that mental space of being able to be truly who you are. And it's a testament to, if you're asking me to come have a seat at the table, because of who I am, then I need to be who I am.
Exactly.
Yeah. So yeah, I appreciate that. And also in having my own business, not all money is good money. And now I understand what that means. And so in teaching classes, I'm not going to sugarcoat, right? It's not a bakery. I'm doing nursing education.
Right.
Sugarcoat. You know what I mean? Don't shoot the messenger now. I don't make the news. I just report it. And so if people have a problem, right, with that information, then maybe I'm not the instructor for you. And so, as you said, that's healthy for me and how I can being true. We work too hard to be in the spaces that we're in, and have the businesses that we have. And so to not be able to be who I am and be able to present the facts to people would be doing a disservice. So I 100% agree with you. Agree with you there. And so as we wrap things up, what do you think? What lies ahead for you in the next 5 years?
We are kind of at this transition point as an organization. I would say when I started in 2018, I started with a need that I felt I needed to fill, and really without like all the knowledge and the tools to do that, I just needed to jump in and do something. And so now we are in our 6th year, and we're kind of working backwards to refill some of those things. Like I always had another job while I was running this nonprofit, and I wasn't able to fully dedicate my brain to just this one thing. And so now that I can, having brain space really makes a difference with your ability to think. But it's helping to create the vision of where we want to go as an organization. We're currently rewriting our mission statement to make sure it really speaks to the work that we actually want to do and where we want to go. We are about to launch board applications so that we can have new voices and new thought into the organization to help us grow. We've done a lot of work in the direct to client space, and that's amazing. We will continue to do that. But the broader, bigger picture is how can we touch the families that we will have no contact with? And that is the structural change, the policy work that needs to be done. So that is where we are. We're very much in a visioning space. Actually going to write a strategic plan because we didn't have one. So we were just kind of being very responsive to what the community has said they need. And we'll continue to do that. The community is very much the driving focus of what we do. We don't put ourselves in a community and tell them what they need. We are intent with listening and hearing what the community has said they wanted and changing course if that's what it means to meet what they have said they needed. So we'll continue to do that, but how can we grow that past our bubble here in Essex County, expanding, to the entire state of New Jersey, and eventually what's the national work that we could be doing. So we're very much visioning and thinking about those things. And preeclampsia is a big one for us as an organization of really taking that work nationally. There have been so many, I won't even say there are changes. They're just information, baby aspirin, for example. That's not a new recommendation, but I consistently meet families who are not being told this recommendation, despite the fact that they meet the qualifications. So again, I'm thinking about how can we move practice into policy and really take the research and change things. If people were going to do it on their own, we would have fixed it already. So I feel like we need to mandate it, whether that means you lose money because you're not doing the right thing. If there's a policy that we need to make, that's really where I'm thinking about how can we make these bigger changes. So that's what's up for us.
Wonderful. Yes. And I would actually have to agree with you. I went to the, back in November, the APA conference. So American Public Health Organization. And that was one of the things that they mentioned as far as health equity and what some of the issues were. And Black women spoke to that, many of them, of not being offered aspirin and not even being aware that it was a recommendation. So going to their appointments again, which is why we're saying a lot of these deaths are preventable, and it has nothing to do with, like we're saying, educational level. Most of the I sat on a morbidity and mortality review committee, and these women were making their appointments. It wasn't about not going to the doctor. As you said, it's just not being offered the things that they should and being provided the care that they should be provided. So
quality care, right? I think that's what people think. I have a doctor, I have insurance, I can go to this appointment. But if you're getting very poor quality care, it's like you might as well not be going, because you're not getting what you should be getting as part of that care. So it's not just access. I think people need to also think about it in that way too. Most people do have access. There are places where there is not. But for the most part, people do have access. It's just that no one cares enough to listen to what their complaints are. No one cares enough to read the research and actually do what's required with their relicensure requirements, right? We're all required to take education as part of our renewal of our license.
Right.
But we know there are ways around that. So we want to make sure that we are with providers who are listening to us, taking our concerns seriously. And we need to spend the time interviewing those people the same way we would research a restaurant, the way we would buy a new car. And we also need to recognize not everyone can do that, right? Because Medicaid has a very limited number of people that you can go see, and you don't have always freedom of choice either. But where we can, trying to protect our families as much as we can.
Absolutely. Absolutely. Well, we really want to thank you, Dr. Harris, for your insights and all of the, pearls that you have shared with us today. Rhea, did you have something?
Yes, I do. I have one last question. And so, Dr. Harris, you dropped so many nuggets today, but I do just want to ask, think about someone who's just starting out as a nurse. And also think about someone who's maybe been in nursing for a while and might want to make a change, do something a little different, right? Follow some of your advice. What is one career life hack that you might give those different nurses?
Wow. I think first, there are so many aspects of nursing that nursing school just does not expose you to. And I think that's another reason why mentorship and access to your professional organizations are so important, because you will meet people who are in so many different spaces. When I went to nursing school, this is never what I thought I would be doing. I thought I would be bedside, ride or die for the rest of my life. And then I realized that's not it for me. But I also think we need to recognize, when I look at our attrition in our profession, so many of our new nurses who are leaving because we've only exposed them to one piece of nursing. It doesn't have to be at the bedside. I don't think there is a room in the world where a nurse does not belong. Lauren Underwood is a congresswoman and writing policy for us as a registered nurse. There are so many spaces that we can explore. So I would say, think outside of the box of what nursing means to you and what is the change that you want to create in the world, and where are you going to be most impactful in doing that. I think that personally, bedside has a season, and then, perhaps you want to move on to do something else. But I think we always think about growth in our career as going up in the ladder inside a hospital system. We don't often think about what the growth opportunities are outside of the hospital. The community could really benefit from the presence of nursing. Entrepreneurship, starting your own business, right? So I've learned over the years, I'm not a good employee. So this is what works for me. But I think you will learn that. You will discover yourself. So I think taking the time to do those things. And then I guess my last thing I would say, one thing I've learned from the business world is not waiting for what you're going to do to be perfect. And one of the examples that was shared was Windows. When Windows first came out, it was Windows 1. And I don't even know what Windows we're on now, right? But they launched it and then they did stuff to fix it and they released a new version of it, right? And then we got that update and then a second version of it. It just keeps going. You continue to improve over time. But if we wait for the perfect moment, the perfect scenario, that time is never going to come. So whatever it is, just do it, fix it along the way. The saying is MVP, and I'm probably going to get it wrong because I always say it wrong. It is your most valuable product, right? get it good enough so that you can launch it and then keep working on it.
Okay. Well, this is my first stab at the podcast. And PC. Okay. I can accept.
And you're killing it. Doing an awesome job.
Thank you. I can certainly accept all of your advice. And I know there is somebody listening who can follow it as well.
Absolutely.
So, Dr. Harris, I just want to say this conversation has been really impactful, I believe. And I hope that the listeners take away all that you've said, starting with the omnibus bill and those things that are important to your organization as community-based, but also taking away listening and being curious and pushing back on the status quo. Here's what you're supposed to do.
Mm-hmm.
Wait a minute. No, I don't think that's right. I want to serve our patients better. And that doesn't have to be at the bedside. So I think you have just laid some really great groundwork going forward, talking about how to welcome in moms and their families, and just sharing how you've really grown the Perinatal Health Equity Initiative. So congratulations to you on the work that you've been doing out there, grassroots, learning about the community-based relationships that you want to water those seeds so that they keep growing, and working with your team, taking care of yourself. That's a lot.
It is.
Yes. And so thank you so much for joining LaShea and I today, having this conversation, providing some really great resources that we can share with our listeners. We appreciate your time.
Thank you. Thank you so much for having me. It's been a wonderful conversation.
Absolutely. And so to all of our A1 Insights listeners, we appreciate you tuning in and giving us the privilege of your time. We ask that you please share how much you enjoyed this episode by leaving us a review and by telling a colleague and a friend. You can visit awhon.org/podcast to read Dr. Harris's full bio and download the resources that she shared with us today. You can listen wherever you stream your podcast, and you can watch us on YouTube. Thank you again. Be well and stay safe.